Hello, I'm Christophe Leclercq and we are in Barcelona for the 2018 European Autism Association Congress. This is the end of the second day of this Congress and we have today a lot of very important sessions with innovation and very new insight about device therapy and ablation. To discuss about all this topic, I have the pleasure to be with Angelo Auricchio from Switzerland.
Hello, Christophe.
And Helmut Puererfellner from Austria.
Hello, Christophe.
So, Angelo, we start with you.
Okay.
And so, you have a very interesting session entitled 20 Years After Medit. Who is at risk of sudden death?
This is a good question, and I think now is still something that we want to work on. First of all, let me say that I would like to pay a tribute to the really founding father of the primary prevention of sudden cardiac death, Arthur Moss, who unfortunately passed away on 14th of February. I think we need to give him really all our thoughts and really to thank him really for all the hard work that he's done. So 20 years after, I think first of all the first things is apparently we need to refine probably the risk of sudden death in the general population. So as the therapy is getting better and better, probably the risk of sudden death is slightly decreasing, I would say. At the same time, now we have two wonderful trials, like the VEST trial, which has just been presented, and which apparently is challenging all what we have learned about early treatment of myocardial infarction with the defibrillator. So, because the data now suddenly are questioning whether really what we learned about 15 years ago is the right thing. So essentially we have now that ICD or the VEST seems to very nicely protect those patients after myocardial infarction. So I think that is really the big hit for me. Apart from that, interesting is also the notion that in non-ischemic cardiomyopathy patients, so we have after Danish, we also have to start rethinking about our process or our indication. And the interesting part that has been really put forward is the role on non-invasive cardiovascular imaging, so essentially scar evaluation by CMR as one of the key and very important way to select patients.
Thank you. What do you think, Helmut, about patients with non-ischemic cardiomyopathy?
Well, the thing is, it's really critical to understand why sudden death can occur and what is the problem and what is the patient at risk. And to give everybody an ICD is not the solution, we know now. And I think what I learned from year to year more is to look at the patient's profile. And if the patient has a high burden on concomitant disease, renal function, atrial fibrillation, some vascular disease, then the benefit of preventing sudden cardiac death will decrease. So we have to find out the patient first with scars, who has a lot of scars, but secondly also to find out the patient who has a lot of competing risk, which is not the best one, and the patient who is in the middle, not low risk, very low risk, but not very high risk, in the middle. And this will be the best patient to target.
So I have to say, sorry, Christophe, one of the interesting contribution that we had also here is about the role of women. So, because apparently women who undergo ICD or may have an indication to CRTD, first of all, we have much less women who are indicated for one reason or the other one to ICD or CRTD therapy. So I think this is something that we really probably need to understand why we have a much lesser referral that we probably should have. And the second one, apparently women have also a much lower risk in general, or a much greater benefit, on the other hand, by CRTD in particular.
Thank you for the transition, because I want to discuss about CRT. And you know that in about 30% of the patient we have a non-response to CRT. So what to do for this patient?
Challenging question. So we may probably have much longer time than probably we have been allowed to. There are a number of things that we have to consider when we talk about CRT non-response. So first of all, about the definition, but I think this is probably not the right moment to talk about that. So, but also there are probably different mechanisms by which a patient may fail to respond to CRT. There has been very nice session highlighting, for example, the role of frequent atrial or ventricular extrasystoles. So, and I think now there is a really common view on the fact that if the patient, before he go to CRT, has very frequent ventricular or atrial extrasystoles, might undergo first ablation and then wait a certain time before he go or is going to be considered for CRTD. On the other hand, once a patient has a CRTD and now shows by a device counter or because he's becoming symptomatic as frequent atrial or ventricular systole, then he probably have to be really be considered for an ablation as well. So that is really, I think, one of my key take-home message from this session. There's also mitral regurgitation is also a major underappreciated problem in CRT. I don't know what is in your population, but at least according to our experience, about 15 to 20% of the patients retain mitral regurgitation, severe mitral regurgitation, or show mitral regurgitation. And the other things, what is I think is quite also important, is about how we can best evaluate lead position after CRT, because it is obvious that everyone is trying to put the lead in the best position he can, but from time to time we may need to do something different.
Let me jump in, is because I was chairing a session today on late-breaking trials innovation, and the first report was very interesting on that, because they use MRI pre-interventionally. So they look at the scar, where the scar is, in order not to pace there, of course. They look at the phrenic nerve when doing a CT, not to pace there. Okay. And then you can put the data, get the data into your lab, and you can merge it with the fluoro. And then they can clearly target, and you can clearly target the best site. And I think part of the problem, aside from extra beats, is also malpositioning. What do you think?
Well, I think you're right. So certainly avoiding scar is a key determinants of response to CRT. On the other hand, I have to say, I know what you're talking about. It was a really beautiful contribution, and this is very much in line with some other literature that we have seen recently about the use of multimodality imaging for improving outcome of CRT patients. The interesting part of this that still in about 20 to 30% of cases, despite all these wonderful MRI, CT, you only have one vein, which unfortunately goes exactly in the region or in the heart, in the scarred area. So, and indeed, in the end, you have 30% of the cases that, despite all these, you are not able to fix.
Exactly. So now we will move to another topic, because today's EHRA released a new practical guide for NOACs in patients with atrial arrhythmia. So Helmut, what is new?
Yeah, well, I attended that session in the morning, and we talked about it because it was a morning session starting even at 8. And despite the fact that it was 8 o'clock in the morning, nobody was first asleep, and second, it was overflowed. So we had a lot of participants there, and Jan Steffel and Hein Heidbuchel were quite happy to have that. They worked hard.
They paid. I think they paid for
maybe they paid
for attendance. I'm sure about that.
But you know, Hein Heidbuchel had published this in last edition was in 2015, and it's widely accepted. It has a high download rate, as you know, so it's very, very well accepted. And now they have worked on the next version, which is now come out. And what I've learned, just some of the ideas. First, for example, there is still the problem of how you would stop before a procedure and how you would reinitiate the therapy afterwards. And they have now very nice illustrations to show, for example, in AF ablation, what you can do. And just one thing that I have heard so many times in my clinic where I work, I don't give the NOAC on that day, I give enoxaparin. Mm-hmm. And they clearly state, and that's very urgent, I think. This is no sense.
Right,
it's no sense to replace.
So to the bridging, I agree that the bridging is
no
the
sense.
worst and the worst things that you can do.
That's it. And I think this is clearly pointed out, and I have learned that. So I think that's very important.
My point is also what's about device patients. So how you deal with device patients. So is any discussion about can you continue the NOAC at the time when you do the box exchange? Can you do the NOAC at the time of new implantation, or how to deal with that?
Yeah, well, they have very nice illustrations on that, and the bottom line is, if this is a routine elective replacement, you can go on and not withdraw any anticoagulation.
So it's a very well written document, and we can encourage the audience to read this document.
Yeah.
So now I have to thank both of you for this very important and fruitful comments. And I know that tomorrow we will have also a very exciting morning session with a very important leg-breaking trial session and also the highlight of this Congress. Thank you for your attention, and once again, thank you to both of you. Thank you.
Thank you, Christophe.